and rheumatological problems were presented in the emergency department. And I'm speaking to you now as an acute physician working mainly in emergency department, admitting medical patients. So that's the perspective I want you to understand. As you can see, musculoskeletal problems are common, and acute joint pain is amongst them. It's worth noting, however, that many of these, even those with obvious rheumatological problems, are not necessarily referred to rheumatologists. And often we go to orthopedic surgeons. And this is a worldwide problem, largely, in my opinion, due to the poor visibility of rheumatologists at the acute end of hospital services. Their visibility in the emergency departments tends to be low, because it is, after all, mainly an outpatient and clinically orientated specialty. I've always argued that their presence and visibility is so important, and you can see that it's manifest by the numbers of patients presenting to emergency departments. The pattern of rheumatologic problems that present themselves are fairly obvious, and I'm not going to go through the enumerate these, but there may be patients with no rheumatological problems but have complications or some worsening of their disease. But there may be patients, and often are, people with rheumatological symptoms, or symptoms that could be rheumatological, and who lack a diagnosis. This was another survey conducted at St. Thomas's Hospital, which tried to identify the pattern of rheumatological problems coming to the emergency department. It was an imperfect study conducted by one of the trainees in rheumatology over a 6-month period. It was imperfect because not all the patients who were presenting could be captured. It was prospective and conducted by near daily visits to the emergency department. So over that period, of 199 cases, on the top of the box was a crystal arthritis, and then others, as you might have anticipated. So I think I've illustrated that there is a real need to have access to a rheumatologist for patients presenting to the emergency department. Well, why? So often we're dealing with complex problems which only the expertise available in a rheumatologist, invested in rheumatologist training, can really solve. So we're talking about quality of service. The other thing is education. If a rheumatologist attends to a problem, either on the ward at request or in the emergency department, there are opportunities for teaching, there are opportunities for the requester to learn a lot. And those responsibilities are those of the rheumatologist. It's also an opportunity for people to learn skills such as joint aspiration and joint injections, and ultrasonography of joints and soft tissues. I would emphasize that there is great value in someone, a person, responding to a request, rather than having a telephone conversation. As I've already said, the opportunity for providing education, for teaching practical skills, and most importantly, for making sure that the details of the case are recorded accurately. How good rheumatologists are responding to requests? Well, many of the specialties who are called on have reasons for not coming within the next 10 minutes. And some of the reasons I'll tell you in a moment, but it's not always someone with a consultant who responds to a request, and it's not always someone who's got a great deal of experience, and that's true of rheumatology as with all the other specialties who might be summoned to see a patient. And not always an anachronous response either. Many of the specialties have good reasons. They will say on the telephone, sorry, I'm stuck in the cath lab, or can you just get these investigations done and let me know, and I'll come and see the patient, and so on. Rheumatology is one of those specialties where procedures, although some procedures are important, are not stuck on procedures, and so there are a few excuses. So the rheumatologist has no excuse whatsoever for attending a patient in the emergency department. You can provide supplementary ways of dealing with requests, such as local guidelines for dealing with acute arthritis, and I'll show you an example in a moment, and protocols which are accessible online. These can be a value out of hours, in fact have a role out of hours, and can supplement availability. So regular specialist hot clinics are another way of dealing with referrals that can't be managed by personal attendants of a specialist, by a rheumatologist in the emergency department. But hot clinics are only of value if there's space for some patients within 1 or latest 2 days. There's no point in having hot clinics, which I've been familiar with, where patients have to wait 2 weeks before they're seen by the specialist. Another useful way of dealing with patients who have an acute problem that can't be seen immediately is to park them in an ambulatory care facility, which we have numerous examples of in the UK, and where I worked most recently at St. Thomas's and now at King's College. We have ambulatory care facilities where patients can wait until the available specialist is free to see the patient. But that's a system that can also be abused by the specialty, and it is abused by rheumatologists who will ring and say, I can't come now, the patient come back tomorrow, or even at the end of the week. This is an example of a protocol for acute arthritis, available online, but it's not a substitute for the personal presence of a representative of the specialty when we're talking about rheumatology here. Referral to hot clinic, okay, has some value, again, not a substitute. I'm just going to give you a few examples of how the rheumatologist can help. So here's an 84-year-old lady who fell over. She's got swollen wrist, it's not fractured, with a little laceration. What is it? Rheumatologist might be asked to see because it seems to be swelling of the wrist joint. And an aspirate of that joint shows that the fluid is actually turbid. So here's something that the young doctor asks the rheumatologist is learning. If the fluid allows you to see through it, it's clear and it's non-inflammatory. As in this example, you can see the numbers on one side and you can't see it on the other, so it's clear. So we're dealing with inflammatory problems. So what is it? Rush the fluid to the laboratory, look down the microscope. Well, this is a facility that's ideal but not available everywhere, I can tell you. And then you see the pyrophosphate crystals on the microscope. If you're lucky, you have a polarized microscope. The facilitator that allows you this lovely color picture, and you will occasionally see urine crystals in this dramatic picture illustrated here. I did put a microscope in the emergency department at St. Thomas's Hospital about 8 years ago. And my wish was to try and teach people who are interested in looking down it, because even with a non-polarizing microscope, you can see crystals. It is, after all, in this experience, the most common cause of an acute arthritis comes in the emergency department. Crystal synovitis, either gout or pseudogout. And if you're able to make a quick diagnosis, you can treat it and send the patient away. You know, there are lots and lots of unnecessary admissions of patients with acute arthritis due to crystals who get admitted to wards. That microscope disappeared within 6 months. I have no idea whether someone hid it so that I couldn't pester people about it, or whether it was stolen. Well, Well, St Thomas's is in southeast London, so I suspect for that. So another common problem that you can help with, or the rheumatologist can help with, is headache. Is a patient with a temporal artery biopsy, she had giant arthritis. Incidentally, when I worked in Karachi, although I was doing more intense, I didn't see a single patient with temporal arthritis, GCA. Whereas in the UK, it's such a common problem, relatively speaking. So we talk about TA, here you talk about tachyarthritis, in the UK it's temporal arteritis. Anyway, headache is a very common presentation, and a rheumatologist can help determine if they're really dealing with giant arteritis or not, just by examining the patient, doing some very basic investigations. So, another role for the rheumatologist. So one of the skills that you can teach is aspiration of the joints. This patient had rheumatoid arthritis, was thought to have an investigation with rheumatoid arthritis, but the rheumatologist in this case noted that the shoulder was disproportionately swollen and was able to teach how to aspirate a shoulder joint. And lo and behold, what emerged was a patient with rheumatoid and septic arthritis. And here's another patient on anticoagulants, also with a swollen shoulder. So the value of joint aspiration and teaching is a very simple technique to people who are asking for rheumatology opinion. It can be so important, improves the quality of service to patients. And here's another example of learning skills. This patient had everything in terrorism. What's the next important investigation? Well, in the UK, the chest x-ray, more than 95% of patients who are acute sarcoidosis were highly anoptic, but amazingly number of people don't know that, the rheumatologist will. And this patient, if this were a child, if this was HSP, in adults, it's more likely you see a rash like this, a pyrrhic rash, with pain around the ankles. You know clinically this is IgA vasculitis, and you know how to treat it. So if you call the dermatologist, they would definitely want to do a biopsy. A rheumatologist with a little bit of experience will tell you, I can tell you what it is now. I can also tell you how to treat it. So I'm going to hand you just a case report which illustrates the usefulness of having rheumatologists floating through the emergency department. So this young woman had chest pain. She went to a cardiologist at the South London Hospital. She actually saw a cardiologist, but didn't get satisfaction. She was told that everything was fine, her ECG was normal, her troponin was normal, but her pain persisted, and so she pitched up another London hospital, which is where I was working, and the rheumatologist who happened to be in the emergency department as part of the admission team noted she had long fingers and hypermolar joints, and an immediate diagnosis was made and suggested some investigations which confirmed the diagnosis. And later on that day, a second aneurysm was being repaired in the operating theatre. And this is her 3 months later in our clinic, showing features of Marfan syndrome, and with the rheumatologist recognizing that this is a complication, which really probably is safer. So, why am I glad I called that rheumatologist? I knew it was going to be worthwhile. So, my patient was seen quickly, because the rheumatologist didn't have any other distractions. It was nice to see a rheumatologist in the emergency department. Now I know what he or she looks like, and I'm familiar with the specialty. And when I have to refer patients in the future, I know who I'm dealing with. I learned something about the condition, and I learned how to inject a joint and how to aspirate a joint. So it was highly educational. And it was also a great advert for the specialty. I know these people are useful, and I'll call them again. Thank you very much.
asked by Dr. Laura Lewandowski, who is a pediatric rheumatologist. The question is, I like your point of upskilling frontline doctors, GPs, allied health professionals to recognize rheumatic disease. What is the best way to do this? Annual workshops, dedicated in-person training, online training modules, or other modalities?
Ask you to repeat part of that question. What were the four choices at the end?
The four choices at the end is, what is the best way to do this? Annual workshop, dedicated in-person training, online learning modules, or other modalities?
Yeah, so nothing beats being with the student, right? Face to face. That's the best. Because you're able to see what their need to know is. It's all about the need to know. You have to know what your audience needs to know. You have to know what your student needs to know. And it's really difficult to get that unless you're face to face. You have to also ask. Prof. Salman and I was asking me, do you use a questionnaire? Do you give your student a questionnaire and say, what do you want to learn today? And instead, we mostly just present them information. It's like a present. I give you a present, it's called my knowledge. But the student may not want your present. So I think online modules are nice that way, in a way, because the student can say, I'm interested in that and not that. So maybe that helps. I think workshops are great, in-person learning, team-based learning, problem-based learning. These are like ideal things compared to the traditional model, which is the most common model, which is a lecture. So modules, team-based learning, in-person learning. What was the fourth one?
First, the fourth one was, what are the options you can do, other modalities that we could consider?
The other things we can do? Yeah, I don't know. I'm not sure what else I would add to that. I do feel like you have to, getting back to the topic of my talk, is you do have to stretch your comfort zone. And so I think when you're a student, or you're, say, you're a practitioner, and you're not getting what you need, you really have to stretch your comfort zone and go find that, whatever that is. There are different ways to learn. Adult learning theory includes that concept. There are different ways to learn.
Thanks, Dan. Could I just say that over the last couple of days we've had some superb lectures, and the lectures this morning were great. And I think the summary, just listening to Terry, is that obvious and common things that the casualty department are hardly ever diagnosed. And that leads to delay in treatment and inappropriate referrals to surgeons. And then we come around to Dr. Faruqi's comments yesterday that we've got a limited amount of resource. And if you don't know what you're doing at the very beginning, you're going to be wasting that resource. And so the question to you, Dan, is, do you think we can rely on IT? Do you think we can rely on people sitting in the community, sitting at St. Thomas's, accessing up-to-date, getting on their FaceTime, talking to you, is going to be the answer?
Can we rely on it, doing those things?
Yeah.
Because of
the fact that resources, you're not going to get Terry.
Right, exactly. Yeah, I mean, there's the ideal and then there's the reality. The ideal is fine to reach for. This symposium is about the ideal. It's trying to get things stretched out to a broader and broader audience. But there is a reality to what's going on out there in terms of NCDs. I mean, the rheumatologist is not the only. Think about being a primary care physician, a family physician. It's easy for us as a rheumatologist, the patient comes in, we can say, is it rheumatology or not rheumatology next patient? But in primary care, my brother was a family practitioner, my father's an internist. It's harder. So this rheumatology CDS, clinical decision support, online access, up to date, does not have that. To use up to date really well, you have to already know what you're interested in. You already have to be looking for lupus. You don't just go to up to date to find out what's wrong with your patient. So we don't have online CDS for that piece, and that's why I built that tool. I actually contacted the up-to-date people in Chicago. I got their medical director on the phone, and I caught him at a wasn't that interested. And I was trying to convince him, that I use 90% of American doctors use UpToDate as their #1 clinical decision support tool. 90%. So if it doesn't have an orientation feature in it, for primary care doctors who see every different type of disease, I think it's limited in what it can do.
Can I just add to this? So, fantastic sessions, of course. In response to what Laura said and what Dan is saying, I think what we have tried to do also is strike a balance between what is ideal and what is practically possible in real life. And my own experience with trying to do the pediatric rheumatology across the Asia Pacific has been that having regular webinars, which are case-based, interactive sessions, they do make a difference. And we are trying to do something like the ILR grant course that Saira and our faculty had run, which is to have a hybrid training that you combine face-to-face sessions, short sessions, which are possible, and then do online, and at the end then you do again face-to-face. So this is something, because access to care and access to teaching material and access to people who are trained is not just, it's the access problem as well, And so sort of, I think working between the two is probably the best way to go forward.
Thank you so much to all the doctors. The next question is from Professor Dr. Sami Salman. The question is asked by Professor Rizwana, who is a medical specialist. The question is, how frequently orthopedic surgeons pick up this CRPS and refer to rheumatologists? Any local experience by Pakistani rheumatologists?
Can you repeat the question, please?
How frequently orthopedic surgeons pick up the CRPS and refer to rheumatologists? Any local experience by Pakistani rheumatologists?
To be honest, I'm not sure about the Pakistani rheumatologist. I'm actually purely referring to Iraqi experience. And I can assure you, many of these patients, unfortunately, they get missed. They are rushed away by orthopedicians because they are not aware of this condition. And it's very easy that one can sort of take a relaxed attitude and say, well, this swollen hand is just unilateral rheumatoid, and he's being treated like this, missing that these people are sweating hands compared to the normal other hand, that it looks darker, that is extremely tender, and that the tenderness is not restricted to the joint. It's all over painful. And the tenderness does not respect anatomy of nerves. So they get somewhere lost in between rheumatologists and orthopedicians, and I felt it's my moral duty to treat them once they come.
Thank you so much, sir. I'm afraid that all the time we have for questions.
Sorry, I'm going to jump in and ask you a question.
Yes, sir.
Because what's really intriguing about some of these disorders is that you sit in Baghdad and it all looks like that. You sit in London and all my patients are under 15, it's always their legs. And although you say sometimes there's not an insult, I think there's something always odd going on with these patients. Like if you swim in England, you swim 4 hours a day, 5 a.m. in the morning, 7 days a week. That's odd, isn't it? And you wonder why your leg hurts, etc. But do you think there's a psychological component to chronic regional pain syndrome?
I would say probably more there's a genetic predisposition, which I mentioned. That's why we don't see it in every patient who gets a hit or fracture or anything. So there is a genetic. I mentioned the HLA association, but psychological, I wouldn't actually, because then really we will be victimizing the